Hi, this is Dr. Luke Haynes, PT DPT. I want to welcome you to the Haynes Method Neuromuscular Dry Needling, our Haynes Method Hybrid Dry Needling Certification course. This is module number 2, covering the cervical and the lumbar spine, the introductory material, and a little course description. The Haynes Method of Neuromuscular Dry Needling Hybrid Dry Needling Certification course is a 64-hour dry needling certification presented in a hybrid context, with 32 hours being live synchronous virtual lecture or modules, and the other 32 hours are live in-person lab sessions. The modules will be broken into 16 two-hour modules, which will occur every 2 to 3 weeks. There will be an introductory 8-hour in-person dry needling lab after the first 4 modules. The advanced in-person dry needling lab will be an intensive 3-day, 24-hour lab session that will occur after the 16th module. Those participants who have successfully completed the entire course and wish to demonstrate advanced clinical competency can sit for both a written and practical examination, which, upon successful completion, will lead to a certification in Haynes Method of Neuromuscular Dry Needling, or the CHDN. The contents of this module, there will be a live virtual module is the introduction of the cervical and lumbar spine. We have already discussed the required supervision by the PT or OT, so we're going to skip that today. We will look at our surface anatomy and our three-dimensional anatomy. We'll then go through needle placement location description. We'll provide some supporting evidence and then some clinical decision making. And then we'll have a dry needling technique demonstration, and that will cover the following axial spine structures: in the cervical spine, the posterior aspect, the Splenius Capitis, the Spinous Surfaces; in the erector spinae group, the Spinalis Surfaces. Longissimus and Iliocostalis will come in the advanced portion of the cervical spine. Moving on to the Semi-Spinalis Capitis, the Semi-Spinalis Surfaces, and then the Multifidus. In the lumbosacral spine, we'll examine the Interspinalis Lumborum, the Longissimus Lumborum, the Iliocostalis Lumborum, Multifidus, and curiously, the PSIS. In some supporting evidence, and an article written by Gildeer looked at a randomized trial of trigger point dry needling versus sham needling for chronic tension-type headache. The results of this study in the dry needling group, the intensity, frequency, and duration of headache, and the scores of the short form 36 subscales were significantly improved after treatment. In the dry needling group, all the effect sizes for headache variables were large. So the conclusion, the results of this clinical trial suggest that trigger point dry needling in patients with chronic tension type headache is effective and safe in reducing headache intensity, frequency, and duration, and increasing health-related quality of life. And it's another study by Tazoon, also with Gildeer there. This is the effectiveness of dry needling versus a classical physiotherapy program in patients with chronic low back pain, a single-blind randomized controlled trial. The purpose, they compared the effectiveness of dry needling with a classical physiotherapy program in patients with chronic low back pain caused by lumbar disc hernia. The results in the study group, the calculated Cohen's effect sizes were bigger than those in the control group in terms of pain, trigger point related variables, and fear of movement. The effect sizes for reducing depressive symptoms were similar in both groups. The conclusion, these results suggest that dry needling can be an effective treatment for reducing pain, number of trigger points, sensitivity, and kinesiophobia in patients with chronic low back pain caused by lumbar disc hernia. Looking at some clinical decision making, we want to evaluate our movement system abnormalities. And in our regions, we'll look at, for our cervical spine, we'll look at, have to evaluate the cervical, the thoracic, the scapula, the CT junction, the ST junction, and the costovertebral junction. Over more into the lumbar spine, we'll look at the thoracic, the lumbar, the sacrum and the pelvis, the thoracolumbar junction, the lumbosacral junction, and the SI junction. The truth is, we can't identify a specific treatment area in the cervical or the lumbar spine without taking in the entire movement system region into account. So it takes a larger assessment area in order to effectively dry needle for treatment. For assessing these movement system abnormalities, we need to look at both our strength, which identifies our myotomes, our range of motion, our movement patterns. Is there symmetry, one-sided versus the other? We also want to evaluate our pain pattern. Is it focal, or is it radiating, or is it both? And then we want to, what I feel is one of the key points of our assessment is our tenderness or our palpation assessment. That is critical to determine more likely the beginning focal point of where we want to start our treatment. And then lastly, our altered sensation. Do we have dermatome issue, or is it peripheral innervation? The assessment, first we want to start in the cervical spine with our cervical vertebral springing. Does that bring into play some specific discogenic issues, some facet problem? And that would give us a good indication there. Then we want to start with our palpation of our cervical tenderness. We'll start at the external occipital protuberance down to T4. So we're going to cover that entire movement region. You can't just isolate it to the cervical spine. In there, we want to look at the paravertebral musculature from the spinous process. We want to move laterally to the articular pillar. So we want to evaluate that entire paravertebral region. We want to move from the center of the suboccipital region laterally to the mastoid process, including the transverse process of C1. We want to move distally from the head down into the neck, laterally on the articular pillar to identify if there's any significant tenderness there. We want to evaluate upper trapezius. Upper trapezius, if there's a cervical, shoulder, cervical thoracic, scapulothoracic region, odds are the upper trapezius will be involved, and that will be included in your treatment approach to any of your cervical diagnoses. And then we want to look at our superior angle of the scapula, frequently overlooked as a point of pain and dysfunction in that cervical thoracic, scapulothoracic region. The levator scap there, that superior angle becomes significant. In this assessment, we want to identify if there's any specific tender bands, any nodules, if there's a focal point, if it radiates a little bit, and then you want to compare that left versus right. You also want to evaluate, is there any aggravation through either active, passive, or resisted movement? That can be indicative of specific problems that you may be looking at. In the lumbar spine, for our clinical decision making, how do we decide where to needle? First, again, we want to start with our vertebral springing. Let's see if there's any specific discogenic, facet problems that we need to evaluate. Then we want to move on to our palpation of tenderness. We'll do our paravertebrals from T12 down to S2. They extend very far distally. So the paravertebrals from the spinous process laterally past the iliocostalis. In the picture that you see to the upper right-hand corner, that lateralmost muscle that you see is iliocostalis, and when considering lumbar, especially in this introductory material, that is definitely a piece that we want to evaluate, and we'll demonstrate how to do that. You want to move further caudally to the iliac crest, palpating there to see if there's any specific tenderness on that. Very important to palpate to the PSIS. A lot of our issues that we deal with in the lumbopelvic region do have, because of the attachment of iliocostalis and multifidus, and then a lot of the ligamentous structures medially, and then as far as also the gluteals that attach and have a partial connection in and around the PSIS. The PSIS frequently becomes involved, similar to how we look at the upper trapezius in the cervical spine. PSIS is frequently a point of pain and discomfort that needs to be addressed as well. Lastly, palpating down into the SI sulcus. Want to assess tenderness in that area to see if there's any tissue inflammation, whether it's deep ligamentous or if it's more superficial, the musculature of multifidus, longissimus, and iliocostalis as it provides its attachment in that SI sulcus. Again, we want to identify if there are any specific tender bands or nodules, or any, if it's focal, if it's radiating a little bit, and then we want to compare left versus right. Again, we want to identify if there's any aggravation in that same region that you've identified your point of tenderness through active, passive, or resistive movement. So in our clinical decision making, we also want to identify when we're talking about sensory issues, is this a central issue, or is it a peripheral? And by central, does it follow a specific dermatome that we see illustrated here, an illustration by Netter. In the cervical spine, we can follow specific pathways of the dermatome from C3, 4, 5, all the way down, similar in the lumbar spine. This is well established where we should expect to see these sensory changes, and if it follows these patterns, then we have a good idea that it could be more related to impingement of the nerve root as it exits through the lateral foramen. But we also, before I move on, I have a little diagram. So I pulled this off of our complete anatomy application. Some may need to do it this way, some may not, but it's just a rotating view of the dermatome map. And I just place it here for illustration purposes. You don't have to use this, but I thought it was interesting to be able to look at the dermatome map in a rotating aspect. You know, the pictures that we look at frequently are just front view, back view. Rarely do you get the lateral view. So we discussed, is it more of a central, a dermatome issue, or is it more peripheral? So when we talk about peripheral innervation, and in the advanced courses of part of this certification series, we'll talk about a number of perineural dry needling protocols. The nerves frequently have areas where they become entrapped, and we tend to see a loss of sensation that doesn't follow a dermatome necessarily, but if we look at specific nerves that provide that sensation, then we can see where those nerves are then providing that. And so this is a nice way to identify if there's some random sensory deficits that seem out of the normal, that don't seem to follow that specific dermatome. Then we want to break down and identify if it meets a specific nerve that has a potential to become entrapped at a more distal location. So central versus peripheral is a concept that we need to look at. The peripheral nerves, we can dry needle. There are very good protocols that you'll learn that can help release that inflammation, that tissue around that nerve in the areas of impingement, and that's again a good part of clinical decision making. So we want to move on to our three-dimensional anatomy. I frequently talk about the importance of being able to understand the muscles, the structures, the tendons, the ligaments of the body in a three-dimensional approach. I feel like that is the best way to understand exactly where a muscle or a tendon or a ligament is in the body compared to where we just see it in 2 dimensions. And a 3D anatomy approach is a very good way to reteach yourself your anatomy. If you're going to place a needle into someone's body, it's critical to know exactly where that needle is headed. So in our 3D anatomy, we're going to look at, again, the structures that we discussed earlier. Splenius Capitis, Spinous Surfaces, Spinalis Surfaces, Semi-Spinalis Capitis and Surfaces, and the Multifidus, and then the Lumbosacral Spine, Interspinalis Lumborum, Longissimus, Iliocostalis, and Multifidus, and of course the PSIS. So in the cervical spine, first is Splenius Capitis. Its origin is the lower half of the ligamentum nuchae, the spinous processes of C2 to T4. It inserts into the mastoid process, the skull below the lateral 1/3 of the superior nuchal line. Innervation is by the posterior rami of the middle cervical nerves. Its action together draws the head backward, extending the neck, and individually it rotates the head to the same side. This is some information that gathered off of Henry Gray's Anatomy of the Human Body. It's public domain from 1918. I'm not going to read all of this. Information is here. It's in the slides that are available to you in the student portal. Feel free to read that. Good information. We've just got a little bit more current that we'll talk about in our 3D anatomy program itself. The Splenius Surfaces. So its origin is the Spinous Processes of T3 through T6. It inserts into the Transverse Processes of C1 through C3. The nerve is the posterior rami of the lower cervical spinal nerves, and its action bilaterally, it extends the head and neck. Unilaterally, its lateral flexion to the same side or rotation to the same side. For the Spinalis Surfaces, the origin is the lower part of the ligamentum nuchae, the Spinous Process of C7 and sometimes T1 or T2. It inserts into the Spinous Process of C2, and its innervation is the posterior rami of the spinal nerves. These are the smallest of the subdivisions. They interconnect the spinous processes of the adjacent vertebra, most constant in the thoracic region, and they can actually be absent in the cervical region, where it's frequently associated with the deeper Semi-Spinalis Capitis. For the Semi-Spinalis Capitis, I'll take a little extra time. Semi-Spinalis Capitis, from a dry needling standpoint, for a patient that's dealing with a headache, upper cervical discomfort, Semi-Spinalis Capitis is a really important muscle, as a lot of the fibers, especially the more medial fibers of this muscle, tend to consistently be in a low-grade spasm with people with C1, C2, C01, and the headache component. Needling those it can be a big game changer when dealing with those. But its origin, the transverse processes of C7 and T1 to T6, and the articular processes of C4 through C6. Inserts into the medial arc between the superior and the inferior nuchal lines of the occipital bone. It's innervated by the posterior rami of the spinal nerves. Its action bilaterally pulls the head posteriorly and individually pulls the head posteriorly and turns it. The Semi-Spinalis Surfaces. Its origin, the transverse processes of the upper 5 or 6 thoracic vertebrae. Its insertion is to the spinous processes of C2 through C5. It's innervated by the posterior rami of the spinal nerves. Bilaterally, it extends the vertebral column. Individually, turns or rotates in the opposite direction. The Multifidus. Its origin, the articular processes of the lower 4 cervical vertebrae. It inserts into the base of the spinous process of all the vertebrae up to C2. It's innervated by the medial branch of the dorsal rami. And its action, it stabilizes the vertebra in local movements of the vertebral column. Global movements, it contracts bilaterally to extend the vertebral column, and it contracts unilaterally to produce rotation in the opposite direction. The multifidus is incredibly important when dealing with patients with cervical, thoracic, or lumbar pain problems because, as in the picture, and we'll look at it closer, because of the depth that they sit laying adjacent to or just posterior to the lamina, it requires deep penetration down to the lamina in order to affect these muscles. If we look at its intervention, the medial branch of the dorsal rami, very frequently when a patient will undergo radiofrequency ablation, multiple of the interventions by pain management providers. This is one of the muscle, the nerves that they're are addressing with their treatment. And one of the drawbacks is you may get a pro of some short-term or even some long-term pain relief related to that procedure. If we interrupt the innervation to our primary stabilizers of the spine, then we're setting up for secondary issues later down the road. So, my opinion, anytime that you can avoid having to interrupt that innervation of that prime stabilizer, let's do that instead. So for the cervical muscles, I'm going to pause here briefly. Okay, so let's start superficial and then we'll go deep. Probably most superficial that we're going to see is our Splenius Capitis. As you can see, it has an origin that extends into the thoracic spine around T2, or C7 to T3 actually is what it says, and inserts into the mastoid process. So I've got that. I'm gonna hide that so that we can see beneath it. And again, we discussed this as being one of our more involved with headache. We get a lot of neuromuscular tension, especially in the medial fibers of the muscle as it comes up to its attachment. So an important there, Semi-Spinalis Capitis. We'll hide that. We'll get into. Here we see, and get it a little bit larger, our Spinalis coli or Capitis, Spinalis Capitis. Sometimes it can be absent, but with our targeted approach to needle these muscles, we're gonna hit that. Beneath that is going to be Semi-Spinalis Capitis, and beneath that or anterior to that is going to be our Multifidus. So. Well, let's come here one more. The Splenius Capitis, again, long, extends all the way up. So with that, in the cervical spine, you have to think, wow, that's an awful lot to try to get to. But I'll, when we get to it in just a little bit, there's a targeted approach with 2 needle locations that we can get all of these muscles with those 2 needles. But we'll discuss that in a little bit more depth in a moment. Oh, my PowerPoint disappeared on me. Okay, so that was our 3D anatomy, just a quick run through of what we're looking at there. Again, I discussed there's a couple of locations that we can dry needle there that encompasses all of those needles. We're going to look at 2 specific places, one up high actually around C6, another a little bit further distally actually into the thoracic spine around T4. That is going to give us access with 2 needle locations to address all of those posterior cervical muscles. We do that at those locations. However, if you have focal tenderness, if you have specific pain either above or below that, those same locations can be moved to address the specific locations of your symptomology, of your pain, of your the reason why you're seeing this patient. But those 2 are always a nice go-to to take a shotgun approach, if you will, to make sure that we interface with every muscle of that posterior group. All right, so let's move to our lab. All right, I can close that. And this is just our cervical surface anatomy. So we'll start by taking a look at our surface anatomy of the cervical spine. We'll start with some anterior structures first to give us a point of reference for identifying posterior structures. And so let me bring up my pen. The structures anteriorly that we'll look at first will be the hyoid bone. Second, we're going to look at the V-notch of the thyroid cartilage. Thirdly, we'll look at the smooth lateral surface of that thyroid cartilage. We'll then look at the cricoid cartilage. And then lastly, the sternal notch further distally. So these would be our anterior structures. Okay, so let me clear that and let's look at it from a lateral aspect. So how these are going to correlate to our structures posteriorly. The reference is going to be a little bit from a anterior inferior to a superior posterior angulation, simply because of the cervical lordosis that we have. But if you place your hand underneath the mandible, underneath the jaw, and let me drop that down just a little so we can see everything here. Okay, so there we are. So we look at hands underneath the mandible. You can have your subject swallow. You'll feel that hyoid bone move. That's going to have a direct correlation with the spinous process of C3. My line is not exactly straight, so let's try that again. Here we go. There we go. So there we have C3. The V-notch of the thyroid cartilage, and these are all palpable, you can palpate them on yourself, is going to orient to C4. The smooth surface of the thyroid cartilage itself is then going to align with C5, and then further distally, and it sits right about here as a smaller, harder structure, the cricoid cartilage, and that is going to orient to spinous process of C6. We drop down a little further distally, again, the sternal notch sitting right here at the junction at the upper end of the sternum, the manubrium, where that's orientation will be relative to the spinous process of T2. Okay, so let's look at our surface anatomy from a lateral aspect. Some structures we'll be interested in here. Number one will be the mastoid process, just inferior to the ear. We can palpate that. Excuse me. Just inferior to that will be the transverse process of C1. Another structure of importance, especially as we get later into our course, will be the lateral arch, our laminar arch. And so that's on most people, that's fairly easily palpable. It can be tender, especially if someone is having some posterior lateral symptoms, but that is going to be an important landmark for us to discover a little bit later. So let's move from here. Let me clear that, and we will move posteriorly now, and let's evaluate some of our important landmarks here. So let's start first with the external occipital protuberance, easily palpable in this area. There are then going to be three lines of importance, really two, but there's three here, so we'll discuss all of them. First is the supreme nuchal line. Adjacent to the external occipital protuberance will be the superior occipital protuberance, and then further distally and much deeper will be the inferior nuchal line. So supreme, superior, inferior nuchal lines. Let's talk about the spinous processes posterior. C1, rather difficult to palpate if it can be palpated at all. Most commonly, C2 is our first spinous process that we can palpate. We can follow by palpating in between each spinous process and the interspinous space to find each of the subsequent spinous process. Of importance, we get down to C5, C6, C7, T1. Then we want to know, okay, well, how do I know if I'm on here? So the easiest way between C6 and C7, a person that's 40 years of age approximately or younger, when you extend the neck, C6 is going to move anteriorly, and then as you extend, it's going to come back to a normal position. C6 does tend to sit a little bit more anterior than C7 to begin with, but in a nice seated position with that extension, C6 will move forward.
C7 tends to be the last of the vertebra that will have some rotation in it, and so if you place your fingers in between the interspinous space between C7 and T1 here, and then do some rotation, you should be able to feel the differentiation between the spinous process of 7 and 1 as well. As you've identified T1, you can move out laterally and palpate the transverse process of T1. If you move a little bit further laterally, then you feel the drop-off. That drop-off indicates the transition from the vertebra itself into the first rib. So that's the vertebral and rib junction interface. So that's rib 1. Likewise, if you proceed down into the thoracic spine, you'll notice that as well. If we've identified T1, we can look at the sternal notch anteriorly, and we know that is T2 as a reference spot. Okay, let's drop into the thoracic spine for our last little piece here. We came in, we identified transverse process of C1 and the spinous process of 2, 3, 4, 5, 1, 2, 3, 4, 5, 6, and then here we are at C7, and then we get to T1, which is our first rib articulation. So for one of our needle placements today, we want to look at something a little bit further into the thoracic spine. So if we look at the spine of the scapula, we can draw a line from the root of the spine of the scapula across, and the general location, see T1, T2, will be between the spinous process of T3 and T4. Generally speaking, we'll call it T4. So that is location. Now the spinous process sits much further inferiorly than the vertebral body itself, but for our point, the root of the spine of the scapula will represent T4.
Okay, so kick that back. All right, so that's our posterior cervical spine, our surface anatomy palpation lab. Do I do that with every single person? No, I don't, but it's good to have that. So here we do have the following slide so that you can have me just not talking about it, but you can follow through each of these locations as well. For the hyoid bone, for the V-notch, the thyroid cartilage, for the thyroid cartilage itself, that smooth surface, the cricoid cartilage just a little bit further inferiorly, then anteriorly that jugular or the sternal notch, which lines up with T2, and on the posterior side the occipital protuberance, center of the base of the skull. Then to locate the C1 spinous process and the transverse process, and then same for C2, C3, 4, 5, and then 6. Again, with that, have your patient or subject extend the neck. C6 should move anteriorly, and C7 should stay stationary. For C7 and T1, again, one's going to rotate, one is going to not. Laterally, we have the mastoid process, transverse process of C1, and then that prominent lateral articular pillar, the laminar arch. When we get to the advanced cervical course or module, that will become a lot more relevant to what's the needling things there. Again, we have scalenes, we have levator scap attaching there, a lot of things that we can needle right there. We just have to be very specific with our palpation so that we get proper needle orientation and placement. All right. So let's move on now to our surface anatomy. And actually, I jumped the gun. We just went through our surface anatomy. What we'll do is move to the lumbar spine. Sorry, I kind of got premature there. Let's move on to the lumbar spine. We'll get to a little bit later a live demonstration of that surface anatomy itself. So here with the lumbosacral spine, we're going to look at interspinalis, longissimus, and iliocostalis lumborum, and the lumbar multifidus as far as our muscles. The interspinalis lumborum, I present these in the introductory class. I have needled these to success, which is to say these muscles have been the cause of issue, of problem for a patient, maybe 5 to 7 times in the years and the thousands of patient interactions that I've had. It's rare that this is the problem, but if there is a situation where that patient is demonstrating very focal, very specific midline discomfort, tenderness, then that may be an area you need to look at. But anyway, for the interspinalis lumborum, the origin and the insertion is the adjacent spinous process. It's innervated segmentally by the posterior rami, and their action is extension of the spinal column. The longissimus lumborum, its origin is the accessory processes and adjacent medial of the dorsal surface of the transverse processes of the lumbar vertebra and the ilium. Inserts in their tendons converge to form the lumbar intermuscular aponeurosis, there with the iliocostalis. It is segmentally innervated, and its action, primary extensors of the vertebral column and the head, acting bilaterally, they straighten the back, returning it from an upright from a flexed position. The iliocostalis lumborum, origin the sacrum, the spinous processes of the lumbar and the lower 2 thoracic vertebrae and their supraspinous ligaments and the iliac crest. It inserts into the angles of the lower 6 or 7 ribs. The innervation is through segmental dorsal rami, and their action, their primary extensors of the vertebral column and the head acting bilaterally. They straighten the back, returning it upright from a flexed position. The multifidus, we discussed this similar to what we saw in the cervical spine. Again, the origin, the sacrum, the origin of the rectus spinae, the superior iliac spine, the mammillary processes of the lumbar vertebra, the transverse processes of the thoracic vertebra, and the articular processes of the lower 4 cervical vertebra. They insert into the base of the spinous processes of all vertebra from C5 up to C2. They're innervated by the medial branch of the posterior rami of the spinal nerves. Their action, they stabilize the vertebra in local movements of the vertebral column. Global movements, they contract bilaterally to extend the vertebral column, and they contract unilaterally to produce rotation in the opposite direction. And then lastly, the PSIS. Again, and the picture on the right, we can see here with, so here's the PSIS. We have gluteus maximus coming over and having attachment onto that lip. We can see the thoracolumbar fascia as it's coming down. It's got attachment on here as well. Right here is the iliocostalis. It's converging down. Here is longissimus as it's making its way to its terminal attachment. And then underneath that we have multifidus. And then we have the subsequent sacroiliac ligaments that are around here as well. So although there's not a muscle overlying it, the PSIS has a tendency to have a significant amount of pain, tenderness, and inflammation associated with it. So frequently that lumbosacral, lumbopelvic area frequently has point tenderness there, and frequently I will dry needle directly onto that. So let's look at our 3D anatomy of our lumbar muscles. Okay, so that is cervical. Let me switch here. Okay, so checking with my moderator. Very good. So when we look a little bit deeper into, and I'm going to expand that there. Okay, so as we look here,
There's some stuff here that we're not going to really be dealing with. Sorry, I'm dealing with my program here. All right. There we go. So there's some things I'm going to get rid of. Serratus posterior, inferior, we're not going to talk about that right now. We'll get to that, but it's not part of what we want to talk about right now. In here, we also have our QL, our psoas. That's not anything we're talking about today, but we will get definitely to that when we get to our advanced module. So in the lumbar spine, we'll go lateral, superficial to deep, and more medial. So here we see our iliocostalis, and as you can tell, it actually isn't just part of the lumbar spine. It extends all the way into the thoracic and even a little bit higher. So it is easy to palpate, and we'll demonstrate that. One nice thing is its lateral border gives us a nice location for its underlying quadratus lumborum. So that's key that we'll use a little bit later. I hide that. And then we get more to our longissimus. And so again, it extends very far distally, and we get a lot of pain complaints in this area. And usually it has more to do with muscular tension in the longissimus. And as we'll see in a second, well, let me go ahead and hide that one. We've got one on the other side. Longissimus just sits posterior, superficial to the multifidus. Multifidus has more of a lateral to medial, more of a almost a horizontal orientation, where the longissimus definitely is more a vertically aligned muscle itself. As you see the longissimus, again, it comes all the way, it goes way up there. So that's longissimus there. Multifidus, again, similar footprint as far as its distal attachment, and all the way up to C2. So we're going to needle a lot of multifidus in our dealing with the spine. I'm going to hide that so that we can get a little bit of a look here at interspinalis. Again, all it does is, I'm going to hide that supraspinous ligament so that we see there are actually two. There's one on either side. So whenever we needle that, and we'll discuss this. This is the only time in the spine itself where we'll needle in a superior direction, just to make sure that we can get into this interspinous space. It looks like there is a lot of room in there, but it is, especially with a little degeneration, it's pretty tight. There's not a lot of room for error in there, but we'll demonstrate how to effectively needle that. And then again, lastly, PSIS. I don't have all of the ligaments displayed, but you can see a lot of the ligaments, sacroiliac ligaments, do start to ultimately converge in that area. Again, with the attachment of gluteus maximus and iliocostalis and longissimus, there's a lot that takes place right there.
Okay, so our surface anatomy, our palpation lab, we will, I'll just go through this first, and then we'll look at the video here. For the PSIS, everything, well, I'll tell you what, let's jump straight to that, to the video, and then we'll discuss that. I'm more of a visual person myself. Let's see here. All right.
Surface anatomy for the lumbar spine. We will start by looking at our inferior aspect and then moving more cranially. So we look at, first thing we'll do is we're going to trace the iliac crest, and we're going to do this on both sides, and follow it down till we can identify the PSIS. If we draw a helper's line between, let's draw that a little bit better, between the PSIS, its orientation is roughly going to be at the level of S2. If we move S2, move superiorly will drop off of that spinous process, and then we can palpate S1. Moving further superiorly, it's a lot smaller, but we palpate for the space in between S1 and the next identifiable spinous process, which obviously will be L5. L5 is fairly deep, and it almost feels like a pencil eraser. If you need to differentiate between L5 and S1 to make sure that you're in your right spot, then what we can do is do a springing action. Use the ulnar side or the hypothenar side of your hand onto that spinous process. L5 will move anteriorly and S1 will remain stationary. We can draw another helper line at the level of the iliac crest, and that will help us identify L4. So from there we can move further cranially, just palpating between each of the interspinous space between the spinous processes to identify L3, L2, and then finally L1. To get a good idea of where we are as far as the thoracolumbar, the TL junction, we can find the 12th rib. We can follow it medially, and at the level of the spinous processes, the spinous process above will be T11, and the one below will be T12. Some more information, and I'm going to clear that information. Some more information. So the facet joints, the zygapophyseal joints themselves, are going to sit basically in line with the spinous process. Inferior aspect will be at the spinous process. The superior facet will be at the spinous process of the vertebra above. So they're going to sit about 2.5, 3 centimeters lateral from the middle of the spinous process on average. The transverse processes, L1, L5, not going to be palpable. L3, probably the largest of the transverse processes. Odds are that can be palpable. More often than not, again, similar, going to find that they're going to sit midway between the spinous processes. L2, L4 possibly palpable. L5 is going to be buried behind the ilium, and then L1 is just too narrow and hidden as well. And so those are the framework for the surface anatomy we need for this course to identify our needling spot, which is going to be adjacent to L4.
Okay, so again, we talked about starting at the PSIS. The helper line there gives us S2, or the spinous process of S2. We can come cranially one step to get S1. Further up, we can differentiate L5 from S1 by doing a springing action. It's smaller than L4, but we can, if we get springing out of 5, we know we're there. If we're not getting movement, we're probably still on S1. And then from L4, 3, 2, and 1, we just go to the interspinous space and identify each one moving further cranially. We talked about the facet joints being at the level of the spinous process. The inferior, superior facet joints are at the spinous process of the superior spinous process. And surface anatomy lumbar, we have just done that in advance. And so let's, why do I still have that in there? We've just done that. So now let's move on to a live demonstration of, a recorded live demonstration of surface anatomy. Again, I keep going over the surface anatomy. Incredibly important to understand what you're feeling, what you're seeing, and to be able to appreciate a three-dimensional aspect. But here is what we just looked at on a human. On our surface anatomy of our posterior cervical spine musculature, we can get a good idea of where we're dealing with posteriorly by our anterior structures. I don't necessarily do this with every patient, but it is a good frame of reference for us to utilize. So what we'll look at is our hyoid bone, our V-notch of the thyroid cartilage, the smooth side surfaces of the thyroid cartilage, then the cricoid cartilage, and then lastly the sternal notch. So if you come in with your patient, with your subject, and just gently place your finger and thumb underneath their mandible, you can then have them try to swallow. When they do that, you will feel the hyoid bone moving up and or down. You want to be careful. It is a fragile structure, so don't try to choke your subject. But that will give you an idea here. So hyoid bone. If we look in a direction, and this line of movement is going to be slightly anterior inferior to posterior superior because of the angle of lordosis in the cervical spine. So we identify the hyoid bone right here. That will give us C3. We drop down into the V-notch of the thyroid cartilage. That will correlate to C4. We drop down laterally, and on the thyroid cartilage itself, we'll be able to feel a smooth aspect on either side. That's going to correlate to C5. We drop down a little bit further, and we're going to find a smaller but more rigid cricoid cartilage, and that's going to correlate to C6. If we drop down a little bit further to our sternal notch, if we translate that posteriorly, that will get us to T2. Okay, so on the lateral aspect, let's talk about our landmarks. Laterally, we want to identify and palpate the mastoid process. Right there. And then as we run distally, our first lateral structure we'll come to is the lateral transverse process of C1. And it's just going to be about a finger breadth below the mastoid process. Very frequently that can be a tender location. Another important structure is the articular pillar or the laminar arch. So we'll want to identify that and its anterior-most border. And there's a reason for that. So that would comprise our laminar arch, our transverse processes on that side. As we get further into the course and talk about scalenes, other structures, this landmark will become incredibly important. So from our posterior aspect, we have several things to look at. First, we want to identify the external occipital protuberance as the skull comes up and forms the crest. It will be the most notable point right in the center. For our sake here, put a little dot there. You don't have to mark that if you don't want to. So superior to that, we have three nuchal lines. The supreme nuchal line, which is a little bit harder to palpate, but you will notice a ridge that runs across from medial to lateral. At the level of the external occipital protuberance, you will palpate, again, a line running across on either side, and that is the superior nuchal line. A little bit lower as the skull starts to dive down in towards the cervical spine itself, and this is deep and this is considerably more difficult to palpate, we'll locate the inferior nuchal line. When we deal with suboccipitals, that line becomes more important for that. But we also want to evaluate and identify our spinous processes. So we come around. C1 is almost always impossible to palpate. An extremely thin person, you may be able to palpate that, but more often C2 is going to be our first spinous process that we locate. And so what we'll do is just march our way down C3, C4, and C5. So we've got a few more to do. What I want to do in evaluating C6, C7, T1, however, is have them do some cervical extension. When you extend the cervical spine, for people, say 40 years of age and under, C6 is going to move anteriorly. Over that age, because of degenerative processes, maybe there's some osteophytes, it doesn't tend to move quite as much, but that's what we want to look for, is a migration of C6 anteriorly. So I'm going to get my best guess of the interspinous space between C6 and C7. And I'm going to palpate onto each of those spinous processes. And so I'm going to have the subject then extend their neck, so we'll lift up, and then C6 does move anteriorly. This is easier done in the seated position. It requires less contraction of the erector spinae, the paravertebral muscles, but it still will move forward a little bit. So I know C6 and then C7 right below. So I can also evaluate C7 versus T1. C7 has a little rotation in it, so if I butt up against the spinous process, I can rotate. That spinous process is moving. If I drop down to my next and I try to rotate here, that one does not move. So this I can identify as T1. If I move laterally off of T1, I can palpate the lateralmost border of the transverse process. I drop off of that, and then I will be dropping onto the costovertebral junction of rib 1. So here is our transverse process. Here's the first rib, and then this comprises the vertebra itself, the laminar pathway here. So I also get interested, so here's T1. We talked earlier about the sternal notch. Its posterior border would be T2. So I know we're sitting here at T1 because we did our rotation, it didn't move. That would make this T2, but I'm interested in T4 for our purposes. For this, the dry needling we'll do here, I want to find the spine of the scapula. I'll use this one over here. And so my spine of my scapula, here is my medial scapular border coming here. Okay, spine of the scapula is going to travel along this direction. I'm going to carry that all the way to what I'll term the root of the spine of the scapula. And we can do it on each side. But basically, between T3 and T4 resides, if we draw a helper line, the spinous process of T4. So if I'm looking for T4, I find my spine of my scapula, and that gives me T4. Again, this is where we found T1 and 7. There's 2 and 3. Okay, in the lumbar spine, where we want to start identifying our landmarks is we'll start distally and make our way more proximally. So first thing you want to do is palpate for and identify your iliac crest. We'll come around, we'll mark those on each side. Ultimately, our goal is to identify our PSIS. So we have a really nice landmark here. I'm going to draw a helper line across. So at the midline of our helper line is S2. Try to draw that upside down. S2. If we come from S2, we'll drop off onto S1, and then between the next step up is onto L5. Now L5 is a smaller spinous process. If you want to differentiate between S1 and L5, you can come in with your thumb and another helping finger
to bounce or spring that. L5 will move. S1 will not. So there's my L5. Okay, so here's 1, here's 5. Now, I'm going to draw another helper line at the apex of the iliac crest. In the midline, that will be L4, right there. So we've got L5, L4. We can verify our location here simply by palpating the spinous processes, moving superiorly. So here we have 4, 3, 2, that should be 1. If we want to verify, what we can do is locate our 12th rib. So we identify that, and then we mark it as it's coming up towards the center of the spine. Okay, coming up to here. So where that 12th rib intersects, the spinous process superior will be T11, and the one inferior will be T12. So here's 11, 12, 1, 2, 3, 4, 5, S1, S2. In the lumbar spine, we also consider our facet joints. So in our facet joints, they're going to basically be at the level of the spinous process. So here we have L2. At L2, and it's about 2 to 3 centimeters lateral from the spinous process. That'll be the location of our inferior facet joint for L2. The superior facet joint will be at the level of L1. And so, roughly speaking, the facet joints correspond to the spinous processes as they travel down the spine. Our transverse processes are also going to be at the level of the spinous process. Because of the shape and the length of the spinous process, L1 is going to be 1 to maybe 2 vertebrae higher than the spinous process. So let's say for L2, let's 1 to 2 finger breadths, more likely 2 finger breadths, I should say. So the transverse process will be more lateral, but it's going to be superior to the spinous process. L1 and L5 really are not palpable. L5 is hidden by the ilium. L1 is too involved with the 12th rib. The transverse process of L3 typically is the largest, and it will be fairly deep, but frequently palpable here. L2, L4 can be palpated. An extremely thin patient, you can get to those. Most of us bigger bodied, and I'm speaking to myself, people harder to get to those, but that's roughly our distance as far as landing on the transverse process.
All right.
On our
Okay, so some general needling considerations. Needle placement location is determined with the first consideration for safety to avoid the danger zones, and the second consideration for the maximal therapeutic effect. Needle location is frequently determined as a certain number of finger or thumb breadths from anatomical structures identified through palpation. When referring to finger or thumb breadth distance, remember that the distance of measure is based on the finger or thumb breadth of the patient, not of the clinician. I'm about 6'3". My finger breadth or thumb breadth is significantly different than someone who is 5'2", 130 pounds. So the difference between, let's say, in the wrist, when we're looking at really close and tight areas, we may even talk about half of a thumb breadth or half of a finger breadth. And so making sure that you use the patient's digit as a rule of measure is important. When needling using the Spinous Processes as a reference, the distance is from the lateral aspect of the Spinous Process at the superiormost aspect. So if you can identify that superior lateralmost aspect, that is where we're going to measure our finger breadths. And the reason for that is that gives us right in the center of that lamina, which is our safety net, to make sure that we don't needle into the vertebral column. So superior lateral aspect. In areas where there is a palpable bony linear surface, such as the spinous process, the tibia, the spine of the scapula, you can frequently use a profundus grip and do that to hook over those bony landmarks. And when inserting a needle, first determine the desired needle placement location. You're going to use your index and your middle fingers. You're going to apply firm pressure as you splay those fingers apart to tighten the skin at the point of needle insertion. We're going to rapidly tap the handle of the needle that extends beyond the insertion tube to quickly depress the needle through the outermost layers of the skin. We'll remove and dispose of the application tube and then grasp the handle of the needle in preparation of advancing the needle in the desired angulation and depth with or without a backdrop. Very important. So as you start dry needling, one of the biggest challenges is not getting that needle through the skin. And so it's incredibly important. A rapid tap, splay that skin, get it tight, rapid tap through the skin. That decreases the surface tension of the skin, allows that needle to penetrate with a lot better ease. And then once it's through there, you don't run into the issue of the needle bending or bowing out of the way. It's a lot easier to advance the needle if you'd follow that. Needle manipulation, pistoning, bidirectional rotation, unidirectional rotation. We discussed that in module number 1, so I'm not going to go over that again here. So let's move on to our dry needling technique demonstration. We'll start with the cervical spine and go through, again, we discussed in the cervical spine, we're going to demonstrate 2 specific points that it covers all of the listed muscles here on this posterior cervical spine. Then we'll move on to the lumbosacral. So for cervical spine treatment, or I say cervical spine, any treatment of the cervical spine, needle inclination is always going to be 1 finger breadth lateral from the spinous process. And the reason for that is to get the depth that we need down to the multifidus, but we want to make sure we land on the laminar, on the lamina itself. We should have a 15 to 20 degree medial and caudal angulation in each plane perpendicular to the skin surface or relative orientation of the vertebra. That way we contact the base of the spinous process at the lamina. In order to ensure patient safety, needling at the spine using the lamina as a backdrop, the angulation of the needle must be inferior, medial, and caudal. Any angulation in another direction would increase the risk of the needle advancing into the spinal column into the dural space. The only exception to that is for interspinalis. Now we're gonna create a safety catch there. With interspinalis, we drop our needle length significantly so that we guarantee that we don't enter that dural canal. So for our cervical spine treatment, I'm going to leave this for reference for you here, but basically in our video we're going to discuss this. Here I will discuss needling. Here our 2 points are going to be, this first one is going to be at the spinous process of C6. We're going to be 1 finger breadth lateral. We're going to go posterior to anterior down to the lamina as a backdrop. And if we want to identify that, again, C6 moves anteriorly with extension as compared to stationary C7. Again, what we do is a 15 to 20 degree medial and inferior angulation from that superior lateral aspect of the spinous process.
The Splenius Capitis, the Spinalis Surfaces, Semi-Spinalis Capitis, Semi-Spinalis Surfaces, and the Multifidus will all be needled in one location. The patient's going to be in the prone position. Needle length, we're going to be 30 to 50 millimeters. Backdrop will be onto the cervical lamina. So we're going to locate the spinous process of C6. It's going to move anteriorly with extension as compared to a stationary C7. Needle placement will be 1 finger breadth lateral from the spinous process of C6. Angulation will be about 15 to 20 degrees, both caudal and medial, down to the lamina as a backdrop.
So again, in this example, what you see is I went from the superior lateral-most aspect of that spinous process, went 1 of her finger breadths lateral, and as I advanced that needle, I went approximately 15 to 20 degrees directed towards medial and towards inferior or caudal to guarantee that I land down on to that lamina. And that's the first space at C6. Again, if you have a patient that's got their focal point is higher, say it's at C3, absolutely you can do this needle placement up to C3. You can literally do that needle placement from C2 all the way down to onto the sacrum. But that guarantees our safety with that in the spine, and that gives us the majority, especially that gives us multifidus, but in the cervical spine, it definitely gives us our this location and our next location that we'll discuss, the location that we need to get all of that posterior cervical musculature. So, on to our point number 2, which is going to be at the spinous process of T4. Here, that is specific for Splenius Surfaces, because in this introductory module and our introductory lab, it's a little risky for a new dry needler to try to needle into this in such a lateral aspect. So we take to get it at its origin, deep into the biggest bulk of the muscle itself, which is from T3, 4, 5, and 6. So we identify, again, spine of the scapula gives us T4, 1 finger breadth lateral, and then 1 to 2 finger breadths distal to the root of the spine to get into that spot.
For Splenius Surfaces, the patient's going to be in the prone position. Needle length will be, again, 30 to 50 millimeters. The backdrop is going to be onto the thoracic lamina. Locate the T4 spinous process as it sits 1 to 2 finger breadths distal to the root of the spine of the scapula. Needle placement will be 1 finger breadth lateral from the spinous process of T4 in a P-A trajectory. Again, 15 to 20 degrees caudal and medial angulation down the thoracic lamina as a backdrop.
Again, locate that superior most aspect. Going to advance that 15 to 20 degrees inferior and medial. Now, right here it looks like it's got a really sharp angle. It's just a view of the camera. It really is in that angle. I will say, as we get a little bit lower, a little bit more inferior into the thoracic spine, the depth, the lamina get a lot more superficial, so you may find that you don't require quite as long as the needle to reach your target depth. And again, as we discussed up in the cervical spine, in this area, if you are dealing with a thoracic issue, This needle placement can be done anywhere along the spine. As a word of caution, again, in the danger zones there at the TL junction, the lamina do get a lot more narrow. It's the narrowest in the body there at the TL junction, so you definitely don't want to find yourself getting too far lateral with the needle placement. If you have to, if you feel inclined, you might even cheat in a little bit there at the TL junction. All right. So let's move into our lumbosacral treatment. Here we'll look at, first we'll go after, did I miss one? I did not. Okay, our longissimus and multifidus. And we treat these together because it's impossible to differentiate them out. They have a lot of the same footprint. Longissimus just seems to be more superficial than multifidus. So for our purposes, we're going to needle this at L4. I do that because it's easy to identify. You find the iliac crest, you create your helper line going across, that gives you L4, and from that superior lateral aspect of the spinous process, then we'll just take our 1 finger breadth lateral, and again, we're going to angle that needle 15 to 20 degrees medial and inferior, or medial and caudal. And that gives us both our longissimus and multifidus.
In the lumbar spine, for the longissimus and the multifidus, patient is going to be here in the prone position. Needle length will be 40 to 60 millimeters with a backdrop onto the lumbar lamina. We're going to palpate for the spinous process of L4 at the level of the iliac crest. Needle inclination will be 1 finger breadth lateral from the spinous process and should be a 15 to 20 degree anterior, medial, and caudal angulation in each plane, perpendicular to the skin surface or relative orientation of the vertebra to contact the base of the spinous process on the lamina.
So I find my helper line, I come across, that gives me L4. I locate the spinous process, and then 1 finger breadth lateral. I then advance 15 to 20 degrees inferior and medial. On that particular needle, previously I discussed the importance of a rapid tap. I didn't do as rapid of a tap as I should have. You saw that I had to grasp that needle a little bit more aggressively to get through the skin, the surface tension of that skin. That's why it's so critical for patient comfort and efficacy of needle placement itself. A rapid tap gives us that ability to get through through the skin and get down to our target depth much quicker. For our iliocostalis, what we're going to do here, again, the patient's going to be in the prone position. We're going to grasp that lateral border of the rectus spinae group, which is here on the lateral aspect. We're going to use a profundus grip, and we're going to apply firm pressure. Now, with the iliocostalis, we're going to drag the fingers across from lateral to medial, and iliocostalis is just going to bunch up into our fingers. We're going to butt up, and it's going to hit our distal aspect of our fingers. We do that, then going to splay, and then we're going to advance the needle almost in a horizontal plane. It's a 45 to 80 relative to that plane. So not going P to A, but almost going from lateral to medial. More often, newer people dry needling will do it almost horizontal, as long as that muscle bulk is there. Horizontal towards the spinous process more than towards the lamina. As you get more versed in it and more comfortable with where that iliocostalis is, then you can drop that needle a little bit more anterior. But don't forget, you also have to do a little bit of an inferior or a caudal angulation as well.
For the iliocostalis in the lumbar spine, the patient again is going to be in the prone position. Needle length is about 30 millimeters and there is no backdrop. What we're going to do is grasp the lateral border of the rectus spinae group with a profundus grip. We're going to apply some firm pressure and splay the index and middle finger. Here we're then going to needle 3 to 4 finger breadths lateral to the spinous process of L4 with a 45 to 80 degree medial and a 15 to 20 degree caudal angulation in each plane perpendicular to the skin surface or relative orientation of the vertebra.
So we find our location, and then I'm going to use that profundus grip to butt up against that lateral border of iliocostalis. And then again, a little bit of an anterior tilt, but really I'm going to just get into that more superficial muscle there of iliocostalis. There's a slight degree of inferior angle, but again, I'm not looking to land at the lamina here. I'm just looking to get through the bulk of that muscle of iliocostalis. For the interspinalis, we will go ahead and present this in this introductory lesson again. Maybe 5 to 7 times I've needled that, and it is the causative factor for discomfort, pain, dysfunction for my patient. But it's typically only in the case when it's very centralized with that. There's no radiating or lateralization, say into longissimus or even out into iliocostalis. Most important here, our needle length is going to be less than 20 millimeters. When I needle interspinalis, I specifically use a 20 millimeter needle. That way I know I leave a little bit of that needle out and I've protected myself from advancing the needle into the spinal canal itself. This is the only, for interspinalis is the only muscle that will needle in the spine where instead of 15 to 20 degrees inferior and caudal, this time we're actually going to go posterior to superior so that we can broach in between the spinous processes.
For the lumbar interspinalis, position is again going to be in the prone position. Needle length here is less than 20 millimeters. We definitely don't want to enter that spinal canal. There's no backdrop. We're going to use our fingers to locate the interspinous space between L3 and L4. When dealing with the spine, this will be the only time that you will have a superior needle angulation, here with a 15 to 20 degrees anterior superior angulation, perpendicular to the skin surface. Caution for depth here, definitely less than 20 millimeters to avoid the spinal canal.
So we're going to needle here at the area of L4 with the lower you get into the lumbar spine, the tighter this space gets into interspinalis. So in this case, if you find that you have difficulty getting in between the spinous processes, what you may want to do is have your patient lay with their abdomen on a pillow to put them in a more of a flexed position, and that will allow a little bit more space to enter into for interspinalis. As we get a little bit higher, L3, L4, L2, L3, that space is naturally a little bit wider. But as we see patients with more degenerative issues, L4, L5, L5, S1, those spaces get very tight. So the pillow underneath the stomach may be a better choice for our effective treatment there. And then on to the PSIS. So what I do here is just palpate, find that PSIS. If you're dealing with a lumbopelvic issue, lumbosacral, lumbopelvic issue, odds are you will be finding some tenderness there on the PSIS. And quite simply what I do is drop a needle onto the PSIS. I'll retract it, redirect it, and basically peck onto that periosteum 2, 3, 4 different locations. That is a nice location for some unidirectional rotation, get some tenting of that deep ligamentous tissue, mobilize that, and that provides a good symptom relief there. For the PSIS, obviously, patient's going to be in the prone position. Needle length here, 3 to 5 centimeters, depending on patient's habitus. Backdrop, obviously, is the PSIS. We're going to palpate the vertical length of the PSIS, and we're going to use the needle to needle through the connective tissue and peck on the periosteum, locating 2 to 3 different areas on the PSIS. So frequently with PSIS, we see that it's very superficial, and that is true. But depending on the amount of connective tissue, adipose tissue, that PSIS may take, I say 2 to 3 centimeters. It may take up to 5 to 6 centimeter needle to get down to that PSIS. This in the posterior gluteal, posterior hip region, needle depth can vary significantly. What I'm teaching you here is a safe approach. As you become more comfortable with the dry needling techniques that we're teaching, you may find that to achieve therapeutic depth that you need to increase the length of those needles to hit your target muscles, ligaments, tendons, and or bone. And so these are a collection in the lumbosacral spine. The one in midline is obviously interspinalis. 2 on either side are longissimus and multifidus. And then to the lateral side, we see coming in for iliocostalis. And as a general treatment approach, those in the longissimus multifidus, those can go up and down the spine in the lumbar spine and provide treatment there. We demonstrated here at L4 for simple access to specific level of L4 based on the iliac crest, but it can be done anywhere up and down the chain. So that concludes the content for module number 3. Module number 2. Module number 3 comes up next. This will be where we look at our junctional zones and our shoulder and our upper arm. Our junctional zones will look at our upper trapezius, latissimus, multifidi, our spinalis, longissimus, and iliocostalis. Those show up again. Anterior, we'll look at pectoralis major. We'll look at the pelvic rotator cuff. Here, glute max meet in men, the tensor fasciolata, piriformis, and then the smaller hip rotators, superior gemellus, obturator internus, inferior gemellus, obturator externus, and quadratus femoris. In our appendicular structures in the shoulder, we'll look at deltoid, infraspinatus, teres minor, teres major. In the upper arm, we'll look at coracobrachialis, biceps brachii, brachialis, biceps brachii, said that twice for some reason, and brachioradialis. So for our homework, I'm going to have a couple of things here. Number 1, we're going to do a self-dry needle of the brachioradialis. I know we haven't addressed that yet, but it's one of the easier ones that we can do to ourselves. So that is the homework assignment, to dry needle your non-dominant brachioradialis. To locate the brachioradialis, you will place your forearm on the surface in front of you in a neutral position with the thumb pointed skyward. We're going to resist radial deviation to identify the borders of the brachioradialis, and then we're going to use a splayed fingers to bracket that. We're going to identify a spot that's going to be 2 finger breadths distal from the cubital crease on the superior aspect, and you may want to mark this spot as I've done in the picture. We're going to insert a needle at this spot. We're going to advance about 3 centimeters or until you reach the radial backdrop. And for our post-module assignment, for those that are taking this for CE credit who want to move on to our lab portion, our post-module assignment, the first, according to Zune, name 4 positive outcomes of dry needling in patients with chronic low back pain caused by lumbar disc hernia. Number 2, name the peripheral nerve and the dermatome of the dorsal surface of the last phalanx of the pinky finger. 3, when dry needling multifidus, what is your primary landmark and how far away from it would you place your needle? And number 4, submit a picture on the dry needling arena of the following structures that you have marked after identifying them on a volunteer subject. This is your surface anatomy. I want you to identify the spinous process of C6, T4, and L4, the iliac crest, and the PSIS. And lastly, number 5, demonstrate that self-DN insertion into brachioradialis.